Hi there everyone, my name is Dr. Nicolene Lottering and I am one of the anatomists as well as the lead for the musculoskeletal component of the anatomy that you'll be learning this semester. So before we get started and dive deep into the nitty-gritty associated with muscles, movements, nerves, and testing of those nerves, I thought I'd create a very short video that just steps us back through some of the main concepts that you learned in year 1 in the Bond medical program of what is considered to be assumed knowledge before moving into the content into year 2. So the learning objectives or the outcomes of this specific video, as well as what is expected that you can remember and recall from year 1, is firstly to be able to describe the regional anatomy of the shoulder. So in particular, we're talking about the bones that make up the pectoral girdle and the shoulder complex. We're also talking about the joint composition, so revising the typical structure of a synovial joint, the classifications of the synovial joint and the components that we find inside that joint capsule, as well as supportive structures that are going to support the glenohumeral or the shoulder joint. Secondly, you should be able to explain the role of extrinsic and intrinsic ligaments, as well as the joint capsule, in maintaining the stability of the shoulder. Be able to demonstrate coordinated movements of the shoulder girdle. So these are going to be movements that are classified as scapulothoracic movements, which is more so the movements of the thorax and the scapula on the thorax, and then what movements are capable at the glenohumeral joint, as well as their range of movement. And then finally, we also do assume that you're able to identify and name the extracapsular ligaments of the shoulder complex, have a rough idea of their attachments to bony landmarks, and the functions of each of these ligaments. In week 9 of Medi 11102, we discussed the composition and the arrangement of the pectoral or the shoulder girdle, specifically discussing the osteology of the scapula, the clavicle, and then their relations with the head of the humerus. So today what we're going to focus on is some of the more specific bony landmarks and markings associated with the bones that make up this girdle. So starting off with the humerus, in particular the proximal part of the humerus, which is going to form our articulation then with the scapula to form our glenohumeral joint, there are a couple of important anatomical and osteological landmarks and regions that we need to be familiar with. So firstly, if we're looking at this proximal end, we have a clear spherical, so round shape structure, which is going to be the ball that forms our ball and socket joint. This smooth area is then going to be the head of the humerus. So it's the head of the humerus that is going to then articulate with the glenoid fossa of the scapula. We then have some elevations on the proximal humerus that we need to be familiar with. And these specific elevations are going to provide sites for muscle attachments, and we call these our tuberosities. So there are two tuberosities. There's a very large and prominent one located on the superolateral surface called our greater tuberosity. This can also be called the greater tubercle of the humerus, and this is important because 3 of the 4 muscles of the rotator cuff will attach to the greater tubercle. A little bit more inferiorly and medially, we have our lesser tubercle. This is an important landmark for the attachment of the subscapularis muscle, as well as some of the attachments of the muscles of the anterior chest. And then further inferior, so located just below the neck of the humerus, we have our deltoid tuberosity. So the deltoid tuberosity is also going to be a really important attachment for the deltoid muscle, which is going to form the cuff-like muscular structures of our arms. Also, what we can differentiate on this image is going to be the difference between the surgical neck and the anatomical neck of the humerus. As depicted on this image, when we're referring to this more inferior line, this is going to coincide with the surgical neck of the humerus, and then more superiorly we have the anatomical neck. So the surgical neck is obviously important when we're considering surgical procedures associated with the humerus. This is also then going to be a demarcation when we're looking at fractures of the humerus. So specifically, if we're looking at the proximal humeral fractures, this accounts for approximately 5% of all fractures when an individual falls on an outstretched arm or directly on their shoulder. So we use the surgical neck as a landmark for whether a structure is going to be intracapsular or intra-articular, or if it's going to be extra-articular. So an extra-articular structure is then going to be at the level of the surgical neck. Intra-articular structures are going to be coinciding with the level of our anatomical neck or head, and this is also then accompanied with injuries to blood vessels that will supply the humeral head. So a common consequence then associated with a fracture that is going to be at the level of the anatomical head or neck is going to be post-traumatic avascular necrosis, which is essentially where we don't have enough blood that is going to supply the head of the humerus, and so the tissue and the cells that constitute the bone are actually going to die or undergo necrosis. A couple of other important landmarks just to familiarize ourselves and review our osteology. So when we're looking at a chest x-ray like this, we have our first rib. We can then keep counting ribs. We know this is first because it passes underneath the clavicle. Notice with the clavicle, we have our acromial or lateral end, which will then form our acromioclavicular joint with the acromion process of the scapula. Anteriorly, we have this beak-like projection, which is going to be the coracoid process. We have our glenoid fossa. The space in between is our glenoid cavity. Also associated with the scapula, we have little tubercles or muscle attachment points. So if it's inferior to the glenoid tubercle, we have our infraglenoid tubercle. If it's superior to the glenoid fossa, we refer to this as our supraglenoid tubercle. On our scapula, we can also then see we obviously have our lateral border. We can see part of the inferior angle, and then we can shade our medial border of the scapula. So this is what a standard shoulder x-ray will look like. This is just another illustration that is then going to depict our important bony landmarks. So if we're starting off with our scapula, you'll recall, so looking at a posterior view of the scapula, we have a couple of major borders. So starting medially, we have our medial border, we have our inferior angle, that will then continue as our lateral border. Superiorly, we have our superior angle, and then we have our superior border. What is very prominent on this posterior view is going to be this long elongated projection on the scapula, which is going to be the spine of the scapula. This continues and curves around laterally and anteriorly to form the acromion. On our scapula, we then have fossa or spaces where muscles will attach. Below or inferior to the spine of the scapula, we have our infraspinous fossa. Above or superior to the spine of the scapula, we have our supraspinous fossa. We can then see here, most laterally in green, we have our glenoid fossa. This is in direct contact then with that smooth projection, which will be the head of the humerus. We then have our anatomical neck in green. We have our surgical neck, that is going to be in yellow. And in this view, we can also see our lateral projection for muscle attachments, which will be the greater tubercle. Note that in this diagram, the surgical neck of the humerus is going to occupy a larger region of space. This is also important when we're looking at amputations. So if we're looking at amputations of the arm, or if we're looking at joint replacements, so if we're looking at a shoulder replacement to replace the head of the humerus and the proximal portion, you'd be looking at making the incision through the surgical neck of the humerus. We then obviously have our shaft that is going to continue. We can see that the acromion is then going to form the roof or the top part of the glenohumeral joint. So the reason, if you haven't figured out by now, why we call it the glenohumeral joint is because we're looking at the joint formed between our glenoid fossa and the head of the humerus. Most anteriorly, we then have our clavicle, just revising some of our important anatomy. Articulating with the manubrium of the sternum, we have our sternal end or medial end of the clavicle. We then have our shaft of the clavicle, and then most laterally we have our lateral end or the acromial end of the clavicle. If we're then considering and revising the major movements that are going to be associated with the pectoral girdle as well as the upper limb, we need to go back and revise the movements of both the scapula and the glenohumeral joint. So firstly, you'll notice when we're talking about the thorax and the pectoral girdle, the first types of movements that we need to consider is going to be our scapulothoracic movements. This is because we know that posteriorly, the scapula or the shoulder blade is going to be in direct contact with the posterior thoracic wall or cage. In other words, our muscles need to help to anchor or hold the scapula up against that posterior wall. And also when we're looking then at the specific movements of the glenohumeral joint, the shoulder is going to help with our extreme movements. So as we can see, the scapula moves on the rib cage as a consequence of the joint motion that will occur at the sternoclavicular as well as the acromioclavicular joints. As illustrated on the slide, starting off with our scapulothoracic movements, these are our movements of the shoulder blade on the thorax. Firstly, we know that we have elevation and depression of the scapula. So elevation is the upward movement. So if we're looking at the movements occurring in purely a coronal or a frontal plane, this is just going to be the superior translation of the shoulder blade. And then we're also going to have depression, so the movement down or inferior. An example of this is going to be if you shrug your shoulders. So if you shrug your shoulders close or bringing them up towards your head, this is going to be elevation. If you slump them back down, this is then going to be depression. And our range of movement is approximately 55 degrees. If we're looking at our side-to-side movements, so this will then be also still occurring in that coronal plane, we have protraction and retraction. So protraction of the scapula happens when we are essentially abducting the scapula, so we're moving it away or translating it laterally away from the midline. Retraction is when we bring it back to the midline. And then the final movements that we have at the scapula is going to be rotation. So we have upward rotation, in which we can see there's going to be both anterior movement as well as a combination of abduction. We also have tilting, so we can see a complete rotation of that scapula going upward. So we just simply call this upward or superior rotation. We also then have downward rotation, which is going to be the consequence of that. And the movement potential is going to be approximately 60 degrees range of movement. If we're then thinking specifically at the movements occurring at the glenohumeral joint, we know that the shoulder is capable of a combination of swing and spin over a range that's far wider than any other joint in the body. Specifically, flexion, extension, abduction, adduction, medial and lateral rotation will occur at the shoulder joint. A combination of all of these will result in the motion of circumduction, which is not really a useful movement to record in clinical practice. As I've mentioned, although the majority of the movement of the shoulder will occur at the glenohumeral joint, the scapulothoracic articulation will contribute to overall shoulder motion in all directions, including lateral rotation. Just revising our movements then. Flexion is going to be the motion then of moving the arm in an anterior direction. So if we're starting in our standard anatomical position and you're raising your arm and your hand towards your face in a sagittal plane, this is then going to coincide with flexion of the shoulder. Extension is going to be if you're stretching behind you, so you're moving in a sagittal plane, the arm in a posterior direction behind your body. When we're looking at these movements, we're essentially looking at the angles that are then formed between the body as a point of reference and then our specific joint. We can also see if we're moving the arm away from the body, we have abduction. If we're moving our arm back towards the body to a standard anatomical position, this is then going to be adduction. In terms of rotation, we can either rotate the shoulder externally or laterally, or we can then rotate it internally or medially. Anatomically, the glenohumeral joint is classified as a synovial multi-axial spherical joint, and this is between the roughly circular head of the humerus and the shallow depression that is going to then be our glenoid fossa of the scapula. The glenohumeral joint is the most mobile joint in the body and is the most frequently dislocated. Its anatomy is a compromise between the requirements for motion or mobility and stability, and both depend on the surrounding muscular and soft tissue envelope more so than the shape and the surface area of the articulating surfaces. So we can see that the surface area of the humeral convexity is approximately 4 times that of the glenoid concavity. We can also liken this joint to a teacup sitting on a saucer. So the saucer being our glenoid fossa, the teacup being the head of the humerus. So given this configuration then, unlike the hip joint, where we have a really nice circular socket to enclose or hold the head of the femur, the humerus is going to fall out of the socket unless it is strapped up. So this is important then when we're considering the actual composition of the joint to know the specific structures that are going to hold or strap the joint together. So firstly, if we're looking at our glenoid fossa, we will notice that there's a rim of fibrocartilage that is going to be on the periphery. This is called our glenoid labrum, and it will then function to actually deepen the articulation or deepen the cavity. We then have a fibrous capsule that is then going to be enclosing the entire joint, and this is made up of fibrous connective tissue. Furthermore, we have a variety of ligaments that are going to be intra and extracapsular that are going to reinforce and stabilize the joint. And then finally, we have muscles that are going to provide concavity compression. So the head of the humerus is held by compressive action of our rotator cuff muscles, and these are going to be attached to the proximal humerus through a muscular tendinous envelope, the deep surface of which will fuse with the lateral aspect of the articular fibrous capsule. If we're then looking at a frontal or coronal view, that is a direct slice through our joint, we can now clearly see, given that it's a synovial joint, we know that there's going to be a synovial cavity on the inside. What we can see over here is going to be then the lining of our fibrous capsule, which is always going to be on the outside and enclosing the joint. We can see when we have bone-on-bone contact, we know that there's always going to be hyaline or articular cartilage lining the surfaces of bone that will be in contact with each other. We can also then see at the shoulder, we have the long head of the biceps muscle that will actually curve laterally and superiorly over the top of the head of the humerus, and it is going to attach just superior to the glenoid fossa at our supraglenoid tubercle. We can also then see we have some rotator cuff muscles, specifically supraspinatus here, that is then also going to attach to the superior part of that joint space. So you may then have come across the term slap lesion or tear. So if we're considering our clinical correlations, a slap lesion is referring to the tendon of the long head of the biceps, which will either slip or tear the labrum. So we can see here it's in direct contact. If we have a tear so usually associated with repetitive use of that muscle in overhead activities, it will actually tear the glenoid labrum, and that is what we're referring to then as a SLAP lesion. As we've also discussed, the shoulder is highly susceptible to dislocations. So the vast majority of dislocations are going to occur in an anterior direction, and these occur when the forearm is forced backwards into greater lateral or external rotation, and when it is in an abduction, laterally rotated and extended position. A dislocated shoulder loses its normal contour because the humeral head is displaced anterior to the glenoid rim and sometimes underneath the coracoid process, as in the case as a subcoracoid dislocation. What is important then to consider with dislocations is the fact that the axillary nerve and vessels may be injured, and then this results in an inability to maintain abduction of the shoulder as a result of paralysis to the deltoid muscle, which we'll cover later on. A posterior dislocation to the shoulder is relatively rare and typically occurs when violent movements produce marked medial rotation and adduction. Examples of this would be in epileptic seizures or electric shock. The upper limb is held in a fixed medial rotation, and external rotation is impossible to perform when posteriorly dislocated. So just reiterating then, in order to ensure the stability of the shoulder joint, because the articulating surfaces do not do this alone, we need to have passive tension of ligaments, we need to have active forces of local muscles, and then we also have this formation of our fibrocartilage ring, being the glenoid labrum, that is going to assist in deepening the joint. The ligaments associated with the glenohumeral joint are the glenohumeral, coracohumeral, and transverse humeral ligaments. So a ligament only restricts a specific motion of a joint when discrete parts of the ligament will become tight or taut. This only occurs at the limits of a specific motion of the joint when the ligament acts as a check rein. For motions that lie within the range of motion, the ligaments have absolutely no mechanical role. So what I've firstly depicted on the slide before we get into the ligaments that are going to stabilize the glenohumeral joint is some of our additional ligaments that are going to help to keep the pectoral girdle together or stable. So firstly, we have our acromioclavicular joints, which is going to be between the clavicle and the acromial process, so this ligament over here. This is going to provide the greatest resistance to anteroposterior displacement of this joint. Our AC ligament is also going to be Y-shaped or V-shaped, and it's going to be a strengthening ligament that prevents upward dislocation of our clavicle. We then also have, between the coracoid process of our scapula and the clavicle, our coracoclavicular ligaments. These act to resist rotation and vertical translation of the acromioclavicular joint. So it's essentially holding or stabilizing the scapula. And then lastly, we can actually see on this view, we have a series of transverse ligaments that are then running from the proximal humerus and then inserting onto the scapula, just around the perimeter of that glenoid fossa. These are going to be our glenohumeral ligaments. So looking at our glenohumeral ligaments, for the purposes of this unit, you do not need to know the difference between the three ligaments, but essentially there are three, and they are only going to be visible from within the joint. These act to reinforce the capsule anteriorly and inferiorly. So together with our coracohumeral ligaments, these are going to act as important stabilizers in an inferior direction in order to help to keep the humeral head suspended. We can also see in general this is going to help to strengthen the capsule or the joint, and if we had to then name these, we'd have our superior, medial, and inferior glenohumeral ligaments. We also then have our coracohumeral ligament, which is superior to the ones we just discussed, that is then running from the coracoid process and then inserting onto the head of the humerus. This will then act to tighten during external rotation, and once again it's going to prevent that inferior translation or slippage of the humerus in a downward direction. Finally, we can see that located in the intertubercular sulcus, so between our greater and lesser tubercles, we have a tendon. So this is going to be the long head of our biceps brachii muscle, passes underneath or through that sulcus, and then will go up and insert onto that supraglenoid tubercle. So in order to secure or hold the tendon of the biceps nicely within this region of bone, in order to prevent it from bowing, we have a transverse humeral ligament, and this acts simply as a retinaculum in order to hold or secure the long head of the biceps brachii. We can also see on this diagram we have a series of additional intracapsular features which are going to be our bursa. So a bursa is going to be a pocket of synovial fluid which is going to help to reduce the friction that occurs when you have muscle on bone. So because there's a lot of muscles that are then going to attach to help to secure and stabilize this joint and allow mobility of the arm, a muscle has to pass over the top of the bursa before it will then have its final point of attachment. You do not need to know the names of the different bursa within the shoulder. You just need to know the fact that there are bursa which are going to be pockets of synovial fluid that just help to reduce the friction.